Sapnil, Dr. Trehan is there.
So his office is locked.
So can you just check there? Either.
Yes, sir, yes.
क्या दिखाता हूँ कि क्या करना है फोन देख ले
Good morning, Dr. Trehan.
Yeah, hi, how are you, Joy?
Fine, fine. Thanks for joining. And without taking much of your time, I know you are busy in the surgery, so I'll start our discussion today.
Please do.
So, good morning to all and those who have registered and viewing it online. So, I have the pleasure to have along with me Dr. Naresh Trehan, the chairman of CII National Council on Healthcare and chairman and managing director Medanta the Medicity. He doesn't require much introduction, but you can see at the back of him all the prestigious awards are there. He has been awarded with Padma Shri, Padma Bhushan, BC Award, and so many accolades. So without much ado, I will start our Fireside chat session. So, Dr. Trehan, as we know that India is slowly and marching to lead the COVID-19 cases across the globe, we have seen a lot of enthusiastic statement at the beginning of the pandemic, and subsequently the numbers are changing and a lot of different kind of remarks policies are getting changed. So my first question to you, do you think that India as a country has managed the pandemic well, or it has been better managed since the beginning?
So, if you look at the starting point where we had discovered that there was enough infection coming into the country, then we were totally unprepared for a pandemic like this. So, we didn't have the infrastructure in the government or the private sector to be able to support if people got sick. Second, we did not have the requisite instruments by way of PPEs, masks, all the other medications that would be required to treat these patients. So I personally have no doubt that the government did the right thing by locking down. Now you can argue whether should have been done over 2 3 days that people could get home, or was it sudden. Those are things that will always be debated. But the ultimate fact is that the lockdown, in my mind, was essential, well done, because if this kind of peaks had come at a time 3 months ago, 4 months ago, we were totally unprepared. And even not we are prepared in some metros and stuff like that, but we are not prepared in the rural areas, even now, in spite of all the time we got. So let's accept the fact that, okay, the numerical increase in number of cases was delayed, not eliminated, delayed. In that delay, as I told you, we got a chance to build the infrastructure and the ventilators and all that stuff, which did two things. One, it provided us with the security that we should be able to deal with it. The other is demonstrated that India can actually rise to the occasion and create new technology very quickly by partnership between the medical profession, the medtech industry, and industry at large. Because this was a very good example of that Agua ventilator was, we were their consultants, Agua was making it, and Maruti came and helped them to upscale their capacity, which was fantastic. It is a good, there many such things happened. It's not only this one. So that it showed that also. Okay. Second thing is that what in this 3-month period, drugs, antivirals that did not exist before were repurposed for this purpose. So by the time the peak started in India, the upward journey, we had the favipiravir and remdesivir and the knowledge of dexamethasone, plasma. So in this journey, no country has been spared. Some have managed it better, but you need to look at the demographics. India's demographics are totally unique to itself. We have clusters which are not, I mean, there are clusters in other countries also, but they are not numerically anywhere near what India has. So, given the lay of the land, given that our personal hygiene and habits and our environment is not conducive today to compare ourselves to any of the Western countries. So we know that this had to happen. If you look at Niti Aayog put out a warning data, said if even 2%, 3% of the population got infected, we will need double the number of beds and capacity that we had at that time. So now what we are saying is several things have happened. One is that in the lockdown, the hospitals were advised or ordered, you can say, stop all elective procedures. Well, it was a theoretical thing that people are going to be locked down, then elective wise, they probably won't come anyway because they are locked down in their homes. And that we should take care of COVID patients. Now, so all major private hospitals took a major hit in the sense that the elective work was stopped and there were not enough patients so the census went down to 20% with COVID and stuff like that. And COVID is a losing proposition anyway. But it is part of our moral obligation to take care of people. This is a national duty, which we are doing, no problem. And although there has been some demands from the private sector to say, please give us better rates so that we can survive. Well, that hasn't happened, but at the same time, we are doing our job. Okay. So, come September, we are totally lost. We don't know. In the very beginning, we thought April, May, June was going to be the end of the June, July would be the end of this whole malady. It is not showing any signs of abating. I mean, we still have close to 90,000 cases a day. And India is actually, shaky underneath the surface because if this goes on much longer, what are we facing? So as far as predicting it, nobody knows. Anybody who pretends, including me, is lying because nobody knows where we are going. Now, every day new information comes. Now we know that there are 3 mutations of the virus. What does it mean? We don't know yet. There is reports that maybe people are getting infected 3rd time. I mean, true or false, I don't know about this report, but at least 2nd time people are getting infected. We can vouch for it ourselves. In our own hospital, we found 2 cases of cancer who had 2nd infection. So I know being adrift, being with this being a much worse virus than we thought at the beginning, I think we need to gear ourselves for a longer battle. because if vaccine comes and it mutates in the meantime, then we are back to square one again. So the only weapon we have is what was proven in the very early stages, and there was some controversy about it in the world, but I don't know why. When it was totally proven that masks do help, distancing does help, hygiene, hand hygiene, surface hygiene helps. So if you are faced with an enemy of this magnitude, and do not take my, I always say, do not take comfort in the fact that 90% will be okay. Yeah, but 90% will be okay, but we don't know the long-term effects on some of them. And we also know that the 10% who actually suffered, they are going to be suffering for some time, and that those 2% or 3% that died, they died. So it's not a joke. So and economic, equally bad is the economic burden of this whole thing. So you get sick. I mean, that's what the last thing India needs: more people to be sick, the activity to come to a stop, economic cycle stops, things will get even worse. So I think that if you look at it from several points of view, you look at private healthcare. Private healthcare will survive. People will have to are coming already for their treatments, and we are seeing an uptake. But the only thing we have to do, have to be responsible, that we take care of these two situations totally separately. There should be no contamination of one area by the other. So if you can do that, then patients' confidence builds and they come for treatment. We are seeing the uptake, everybody's seeing it. So it's a good thing. Long term, every time we feel that there was, because say about a month ago, we were of the feeling that we can wind down our services for COVID. We thought we will close the extra hospital which we had opened mid-year, that we were needed. But suddenly the spike has come. So will it keep again and again? We don't know. If you study the old pandemic, that was 100 years ago, there were repeated spikes for 2 years. Now, is that our fate? So main thing is for people, it's a people's war, aided by the healthcare providers and the whole army of healthcare professionals, and administered by the government in whatever help can come. But it's a people's war. If people don't understand it, we will pay a very heavy price. If people start understanding it and get scared enough to protect themselves, maybe India will not have such a bad situation. So ultimately it comes to that. So it's a long answer to your short question, but I hope I have answered it.
Yeah, you have answered. In fact, you have covered part of my second question also. But as you told that this is a war and where healthcare providers are going to fight, and there is leadership from the government who has to work together. So that leads to my next question. Do you feel that in this fight, in this war, government has adequately involved private in a equal terms as a responsible party to it and involve them? Because time to time we have seen in different states the policies, the pricing, the regulations which have been brought, that has not been perceived as a very private sector friendly policies. So keeping that in mind, the way you are advocating fighting together, do you feel the private sectors have been welcomed, has been asked to join as an equal partner?
The government, I must say, and at least I can speak for this area and at the central government level, there has been a lot of engagement with the government. There has been a lot of to and fro on the facts, on policies, on something. The only distress people are feeling in the healthcare provider industry is not the want of government engagement, but the pricing which is actually forced us. And you take Medanta, which is pretty robust otherwise. that we have had to borrow heavily to tide over the past 5 months. So that is what we were actually trying to lay in front of the government. That look, we are in trouble. I think all of us, maybe I don't know about your situation, but we all were in trouble because of the rates. If it was approved that there will be 10,000 rupees a day, the cost was anywhere 17 to 18,000 for that room. So if you're going to lose a 60-70% of on each patient, it puts huge benefit. Now the question is, what is the if you put on the government's hat and you discuss from that point of view. Now you know that the government, what has the government done? Government has put major portion of their resources at the bottom level, on the ground level, to actually stabilize the bottom, which we must also appreciate in our own way. That if people go hungry, there will be no hospitals left, private people will be left, because there will be chaos. So for our own protection also, we feel, I feel, and I'm not speaking for anybody else, that policy of the government to feed the ground, to keep everybody stable with our huge population of 1.3 billion people, at the expense of people like us who will survive eventually, I think is the right decision. People may agree or disagree with me, I don't care. I personally feel the government is in the right direction. The fact that for the last 6 months, there is no major report of people going hungry, that by itself is an accomplishment for a country. The problem is, how deep do we have to go? How long do we have to go? So the hospitals will recover. I mean, I'm sure I will have very few takers on this call. People will say that I'm selling private healthcare down the tube. Well, this is what I believe. I think I have a very strong national feeling. I believe that we should all stop complaining. We are going to be all right. We are already seeing some uptake. We'll be okay. So there is no reason for us to cry, because we know that it's not that there is so much money somewhere that it can feed everybody and needs of every industry, every individual, everything. So I know I'm disappointing to many people, but I've always said to the government that look, if you could even improve it a little bit, like what my demand was, and our own community's demand from CII and all you other guys, was the money that is owed to us at this time, please pay it quickly. Now, in the first month, that response came very good, because we all received 20% of our money. But then it dried up after that. So that's the only thing the government could have done and can do even now. So the amounts we are owed from CGHS, ECHS, PSUs, these are things that should be released. This is our money. Whatever the bills can be looked at, whatever you release 70%, and then the accounting can be done. Do something to help us. Because when we borrow at 10%, we are again going in a deeper hole. And I can say that some of the weaker institutions will actually collapse. So that's where our main communication to the government should be, not asking for dole, but asking for what is our due. And I don't think that's unreasonable.
So when you say that some of the hospitals will close, but I think already that has started. Many hospitals I know in Mumbai, in Maharashtra, they have started shutting down their operations because of lack of availability of funds. Time to time, in the closed door meeting of our CII Healthcare Committee, I hear your recommendations and expectations from government. One of those you have articulated just now in terms of the payment for CGHS, ECHS patient, ESI patients. But if we ask that what will be the national agenda from the private healthcare sector to ask, to seek from government for their own survival. So what will be top 3 or 4 agendas? What do you think
Okay.
from the
No,
private
no,
side?
very, very good question. Because see, not that I don't want help, not that I want to borrow, that I want anybody to borrow, but being cognizant of the fact that how much money there is in the treasury, I don't think we are getting anything as far as dole is concerned. But what I made a very strong argument about was that can we not take the money at interests which are maybe 5%? It's not a big stress on anybody. The banks can do it. The government can subsidize it. It will make it easier for those people, for us also, to survive easier. So in addition to our money being paid, this was the other ask, that it's easy to do. Okay. Now asking, look, we did ask a few things which in retrospect, I think that it's not possible to say, let the electricity bill be foregone or rates reduced. But the discoms are in such bad shape themselves that you don't expect help from them. So there are areas where there would be great help to healthcare providers to be able to fight better. But the point is, do they have money, or is it an unrealistic expectation where the expectation is that they should pay our bills, and the fact that they can make money available to us at a subsidized rate? That would be a great help. And I think that's still my ask.
So, as you know, this is an event, CII Health Tech 2020, where we are focusing on digital, we are focusing on technology. So, my final question to you will be, what are the roles you feel, or what are the technology you feel can be adopted by private healthcare to fight during this war in a better way? What are the applications? What are the adaptations can be done?
So at the base level, the platform of video conferencing and teleconferencing is well established. The deficiencies that were there before have now actually been worked out very quickly because of the pandemic, because everybody, not only us, everybody is using it now. So that is a well established fact, that will be a platform on which we were always thinking we'll be working as we move forward. In fact, we had made a statement saying that in the future, 50% of the patients will not have to be touched, that we could actually take care of them remotely with the enabling devices. Now, the key word is enabling devices. So if you see the latest 6-lead ECG, which you can put through your phone, which is just being launched by us, it actually gives you at home. You can do your ECG, you can do your blood pressure, you can do fundal exams, you can do many things from your computer at home. Now, if that is the case, then it has actually, what was going to happen maybe 1 or 2 or 3 years from now has happened already. That is one part of it. Technology, the other thing is that as we get familiar with technology, and larger people have been forced to get familiar with technology, which we didn't have. The Zoom had existed, but nobody cared. And the fact that you and I can talk, and Srinath, I see on the lines, hi Srinath, that we can be virtually, meeting much more often than those annual events, and then everybody has to travel, great expense, and disrupting your work. You don't have to do all this. So that's a great thing to happen as part of this, sadly, from the pandemic. So it's good, but we have got used to it now. So that's, I think, all transactions can be done basically face to face, even much more concentrated than you are when you are sitting on a dais or something like that. So that's one given. But I think where we go forward, which is the most important thing, is the use of AI in establishing algorithms which will help physicians from around the world, especially in India, where we do have a shortage of specialists, to be able to communicate very quickly with specialists, to learn from AI and machine learning themselves. You can create pop-up menus, so that, which is not new technology, which is happening for a long time, that you know the differential diagnosis. If you didn't have the knowledge, it will be presented to you. At least you can get it in the right direction. And wherever in doubt, at the press of a button, you can talk to somebody who can guide you right away, and you can visually see. So how many, if we were doing less than 100 video conferences a day from Medanta before pandemic, today we are doing upwards of 600 a day. So
Excellent.
just imagine the number of patients who are being serviced. So what will happen typically? They will, when they need the diagnosis properly, when they need the procedure, of course they'll have to come. But a large part of the lifelong follow-up, where they come to meet you for 5 minutes so that you can adjust their medicines, that can be done remote very easily. Somebody sitting in Bihar already there, but large part of them will become the norm of the future, will become permanent. So I'm hoping that this whole thing, at the end of it, I don't know when, maybe Srinath can tell us more about when the end is coming, but at the end of it, we can derive some benefits of this whole experience. The most important thing that I think we should understand, that you realize that many activities that we did were totally useless, were wanton. Your needs have become limited. You can survive on much less and be happier. So you're not chasing your tail the way we were before. So I think there are definite benefits. This is going to be long-term benefits of all this. But when will it end? Srinath, please enlighten us.
So
Okay.
thank you, Dr. Trehan. I think what
No,
you have
it's
very clearly
my
told
pleasure.
that the technology and other things we need to explore and see how we can fight at this time rather than cribbing about it and feeling bad about it. So we
Yeah,
need to see opportunities are coming out of this. So thank you very much for joining today and sharing your views and thoughts and taking time out from your theater and updating all of us.
no,
Thank
no,
you
I
very
enjoyed
much.
it. Thank you very much. And I will keep joining as you go on. I'll in and out. I'll be in and out. Thank you.
Sure. Thank you. Thank you.
Okay.
So now we move on to our next fireside chat session, and we already have with us Professor Dr. K. Srinath Reddy. Very rarely you can see a personality. I suggest Sapnil, please focus on him. I very rarely you can see a personality who has in one hand training in clinical services. He is a qualified cardiologist, and at the same time, he is a public health professional. So currently, he is the president of Public Health Foundation of India and formerly headed the Department of Cardiology at All India Institute of Medical Science, trained in his super specialty area from All India Institute of Medical Sciences. He was appointed as the first Bernard Lown visiting professor of cardiovascular health at the Harvard School of Public Health between 2009 to 13, and presently he is the adjunct professor of epidemiology at Harvard, and that tenure is continuing now. Apart from that, he also holds the adjunct professor post in public health from Emory University and honorary professor of medicine at the University of Sydney. So I can keep on continuing with his introduction. Such a illustrated career, such a illustrated personality, and we are very grateful and thankful, Professor Reddy, for joining us today in this fireside chat session. So welcome to our platform. You are mute. You are mute.
Well, thank you very much. It's a pleasure to be with you today.
Thank you. So our topic, as I have shared with all of you, India's battle on COVID-19, a public health perspective. We are going to talk from the public health point of view. So the first point what we'd like to know, Professor Reddy, that what do you think, what is your take on this origin of pandemic, which is a very controversial topic, but we would like to know your views on that. And how have most of the developing or developed countries failed to manage? Why do you think that all of us have not reacted and responded that well?
Well, as far as the origins are concerned, it's very clear that it's a zoonotic disease. In fact, in the last 60 years, about two-thirds or even more of all new infectious disease outbreaks have been zoonotic, which is transmitted from animals to humans, either by way of a secondary animal host or directly into humans. Many of them originate in bats, but some of them also originate elsewhere. And the secondary animal host can be either birds or pigs, or they can even be pangolins, as in this case. And in this case, it's thought that it originated in the bats, and then it went into the pangolins, and in the wet markets of China, it possibly transferred to human beings. Now, there are also recent studies suggesting that this may have actually entered the wider human population or even the animal population uh, in Myanmar rather than in China, and from there it could have gone to China. Investigations are going on by a special independent committee set up by the WHO, but headed by very eminent personalities, and they are investigating the whole origins of the virus as well. The speculation that this is a laboratory origin at the moment seems to be more of a conspiracy theory, and very eminent virologists from all over the world, including from the United States, have discounted that this could have been produced in a laboratory. Whether this was actually of animal origin and then isolated in a laboratory and escaped from the laboratory, that is something that needs to be still seen. But the origins are very clear that it actually has come in from the forestry, from the wild animals there into the veterinary population, as well as then into the humans. Now, coming to the next question which you asked, why is it that developed countries have been so ineffective in their response? Firstly, we must understand that for several years, the high income countries have not really faced the threat of a major epidemic or a pandemic in terms of infectious diseases. In fact, in 1969, the then Surgeon General of the United States told the Senate, the Congress, that we can now close the book on infectious diseases. And as though to rap him on the knuckles, to teach a lesson in humility, the HIV epidemic broke out. But after that, they have not seen, like the countries of Asia have seen, H1N1, H5N1, and or like the Middle East has seen the MERS. A large number of zoonotic pandemics have occurred elsewhere, and of course, Ebola in Africa, Nipah in Kerala. So the familiarity of their public health systems with epidemic control and epidemic investigation failed. And even in contact tracing, they lost their touch. They depended more on apps than on trained personnel. So, and also in the health systems, the primary healthcare system, which is very much necessary for early recognition of an outbreak and investigation, as well as also contact tracing, those have actually been relatively defunct in some of those countries. And that is why they've also failed to provide an early energetic response, depending mostly on the hospital response as cases mounted and serious cases needed intensive care. So for a variety of reasons, this epidemic has proved the failing of some of the high-income countries in neglecting both public health and primary health care as essential instruments, and including the whole area of epidemic investigation and control.
So, as you told that some of the undermining the virus or epidemic time to time that has caught the developed countries in a wrong foot, and then it has become a major challenge. Now, I remember in Indian context, last week of January, we had the first case detected, and then all till middle of March, the number of cases were in double digit, and we called for the lockdown, and whole world applauded us in terms of calling for the lockdown at the right time. We saw steady growth, but the growth rate was not that high till April end in this country. But even after having such a prolonged, lockdown and all sorts of measures taken, where do you think India has failed? Why the cases, especially now in the end of September, we see every day case loads are going by 85, 90,000. So where we have done wrong? What kind of public health strategies we need to develop for better, scenario for future?
Well, I think we failed in having a staged response and a differentiated response, which actually could build upon step by step approaches. When I say a staged response, if you look up to May 3rd, the first two phases of the lockdown were implemented very rigorously. Then we started relaxing the lockdown, and then in early June, we lifted the lockdown. The latter phases of the lockdown, and particularly the post lockdown relaxation, suddenly resulted in sending a signal both to the administrators as well as to the general public that the danger is past, that we have very few deaths. This virus is no longer posing much of a threat to us. We did not build upon the public sentiment that we still need to be extremely careful even as we resume our economic and social life, and we do need to observe a great deal of public health caution. That message did not go strongly enough. The initial response was centrally directed, and later on, as the states took up the response, again, there was a great deal of variation in the level of application and understanding of the epidemic dynamics, and also in terms of implementing the control measures. And we needed a decentralized district level response at that time, and that did not really happen. Ideally, policy should have been sent at the central level, planning should have been done at the state level, and implementation with a fair amount of context-specific flexibility should have been done at the district level. But we went into almost an all or none phenomenon in which we planned centrally and then suddenly we let loose the states without a very clear-cut planning at that level or even district-wise localized response and intelligence gathering by local information systems with adapted response. The second element is that we probably went in for a national lockdown rather than for having locked down the big cities where the virus entered and contained them strongly. And only when the virus started spreading to other areas, we could have gone into a lockdown in other places rather than having a nationwide lockdown at the very first phase. But it's difficult to judge in retrospect because at that time we were seeing horrifying figures of what was happening in Europe and North America. We were having all kinds of modeled estimates predicting millions of deaths by midsummer. So it is possible that at that time we perceived the danger to be much more than it later turned out to be. But our weak health systems also caught up with us. Our primary care, particularly urban primary care, in the big cities, if the urban primary care had functioned well, we could have actually identified the cases for testing much earlier. We could have done much more energetic contact tracing and limited the spread of the infection. And even elsewhere, our primary health care failed. And even our secondary health care, when we required oxygen-equipped hospitals rather than too many ventilator-equipped intensive care beds, as the recognition came in, we found that even our secondary care facilities were relatively weak. And our health workforce was extremely limited, and they were also under great stress because of the excessive workload and because of they were also falling victim to the virus. The attrition, both because of infection as well as exhaustion, started depleting our health workforce. Ideally, we are supposed to have doctors, nurses, and auxiliary nurse midwives combined, according to the estimates of the WHO after the Sustainable Development Goals in 2016, 2015, 2016, WHO estimated we need 44 health workers of these three categories per 10,000 population. We have 22, just half that number. So we need a much larger health workforce and a better skilled health workforce at multiple levels. And all of these weaknesses have caught up with us. And therefore, we do require many of these elements to be strengthened, whether it's district hospitals or urban and rural primary health care, all of this. And remember, there's also marked asymmetry of these health system resources across the country. And what I have given are general national figures. But if you look at the difference in health worker availability and distribution between southern states, Western India, Central India, Northeast India, you find huge variations. And that is where you are going to have your weaknesses in the health system exposed. You cannot build a very efficient and quick surge response to a public health emergency if your health system has not been functioning well in the steady state under non-emergency situations. And that is the lesson we should learn now and invest in building up a much stronger health system.
So, as we know, irrespective of this pandemic, our healthcare infrastructure is not up to the expectation. Our healthcare resources are always in scarcity, and we acknowledge and accept that. But you mentioned about, contract tracing, testing, and so many other strategies which are supposed to be ideal to manage. And I recall in the month of June, everybody praised and applauded the initiative of the Kerala government because they could bring everything under control and things were getting sorted out for them. But of late now we hear about that sudden surge of cases there. So where did they go wrong? And at the same time, I want to ask the state from where I come from, and most of your audience is attending Maharashtra. So Maharashtra was also shown probably the highest number of cases in terms of death cases, in terms of the positive cases in every aspect. And so what do you think has gone wrong in Kerala in their second phase as well as in Maharashtra from the beginning? Why there is sudden surge of cases here?
Well, it's very clear that when you allow a large number of people to travel from outside the country to come back to India, as many Indians were relocated back to India as evacuees, and also people started traveling after the lockdown ended within the country, within the state. People who were stranded elsewhere started coming back to Kerala, not only from abroad, but from within the country. And similarly in Maharashtra, people started traveling a lot. Remember, the virus travels with people and celebrates with crowds. And you have lockdown to laxity. You allow people to gather in large crowds, whether for religious or political or social reasons, to celebrate birthdays or festivals. The virus actually has a great opportunity to spread. And we did. Even in Kerala, that happened, though much of it came with travelers relocating back to Kerala. But the system got overwhelmed because the people thought that they had already won the battle. Similarly, in Maharashtra, you had a lot of people traveling around from outside the state into the state and from one district to another district. And then, coupled with a bit of a laxity in crowd control, then this actually sets the second upsurge into motion, actually, even before you had the first upsurge fully controlled. So these are some of the reasons why we have failed. If we had actually allowed graduated return to normalcy in our economic, social, and scholastic life, while observing all the precautions of preventing large gatherings anywhere, particularly indoor, and ensuring that we had spent this time in instilling absolute discipline for wearing masks and physical distancing to the extent possible and hand hygiene, we would have actually controlled the epidemic far better. We suddenly let go, and that actually happened to let the virus travel very freely.
So, as you tell, and as I understand, that social distancing, movement restriction, socializing to be under controlled, and so many other practices needs to be adopted, and then only we can keep ourselves safe. It gives us a feeling that our life is going to be completely different than pre-corona period. So everybody, millions of Indians are looking and waiting for the day that virus vaccine will come, and with that vaccination, probably we can come back to the normal life the way we have led so far. So my question to you, and I am one of the privileged person, I get in the WhatsApp group almost every day some updates on that front from you. So now I want to know, I want to share that benefit for the others. Where do you think the vaccine development is happening? Where do we stand? How soon we can get? When every Indian can expect that they can get their own vaccination done in their own, not through any catch, any contact, any influencing person. So when do you think that is going to happen?
Well, let us first recognize that there is no 100% guarantee that we are going to get a safe and effective vaccine. There is a good hope that this is going to happen because there are multiple candidate vaccines which are actually bidding for that position. Several of them are in clinical trials in phase 1, phase 2, some in phase 3, and some are actually under development in the preclinical phase, and which also are likely to enter into the race at some point in time. But we must recognize that any vaccine to be made available has to prove at least two criteria of safety and efficacy, and preferably also hold the promise of fairly long duration of protection. Now, we know, for example, that in terms of safety, there is this huge problem of antibody dependent enhancement, which actually derailed the vaccine for SARS-1. And that can happen with any vaccine. Therefore, we have to watch out for that. We have to watch out for immune complex disease. These are some of the major side effects we should watch out for. Then for efficacy, we know that there is something called the original antigenic sin, in which the actual virus particle fragment or which is utilized for creating the vaccine may be recognized by the immune system, but the whole original virus may not be recognized, and therefore the antibody response may not be mounted against the real virus. And therefore that is a problem that we must look at. We must also find out if antibodies are developed, whether they're really neutralizing antibodies, to what extent the T cell immunity has been stimulated, and how much are these going to actually be effective in terms of duration. All of these are still under study. So we still have to keep up our hope, but at the same time, let our scientific objectivity look at evidence as it is gathered. And you also know that there are multiple platforms that are being used for creating vaccines. The messenger RNA vaccines are the ones that are likely to be developed faster, but whether they're going to be really successful in passing these tests, and whether this particular platform is capable of large-scale production. And secondly, even the regulatory agencies do not have a familiarity with the messenger RNA platform. So what is the time that is taken for evaluating the evidence? All of those are issues. Then there are other platforms, of course, that we know, that we have recombinant protein vaccines used with adjuvants. Then you have also attenuated attenuated viruses being used as vectors in order to carry the genetic material of the virus. So there are multiple vaccines with different platforms. Which of them is going to be successful, we cannot say. But assuming that we do get a vaccine passing all the tests by, let us say, late December or in the first quarter of next year, then you have the logistic challenges of mass scale production, of distribution. And if you have a vaccine that requires 2 doses, that's going to be an additional logistic challenge. Some of these vaccines seem to require cold chain. Some of those vaccines may not require a cold chain. That's another logistic challenge. So all of these come in. And secondly, you also have other vaccines that may be developed, like mucosal vaccines, which can actually prevent even the stationing of the virus in the nose, the entry, rather than actually combating it after it has infected you, the so-called sterilizing vaccine. So we have multiple options, but we still do not have anyone that has passed the test. So I believe that if we do get a vaccine by the first quarter of next year, in terms of passing these tests, and we then mount with adequate prior preparation all the logistical requirements being satisfied, and mount a very strong distribution production network, then it is only by the middle of next year that the first prioritized category of health workers and others with comorbidities and other essential health workers, other essential workers will be getting it. But we still have to keep our hopes alive, but wait for real science to demonstrate that we do have a winner on hand.
So, when I thank you for this detailed information, but I feel sad, and I think many Indians' hope has got now devastated. They have got devastated because 15th August 2020 was the first date everyone was looking for. Then it was getting postponed. Now you are talking about the middle of next year. And then if it is middle of next year, then also it is not assured that the vaccine is going to be really effective. And many ifs and buts are involved in this whole development process. So if that is so, and I assume that vaccine is the only solution, so when do you think that India will be able to come out from this crisis? Is it going to be only vaccine dependent, or there is something else can happen which can make people life easier, or we have to be dependent only on vaccine?
Well, there are three fire escape routes by which we as humanity can get out of it, and India in particular. The first, as you said, is a vaccine. But while we are investing in hope, we have to rely on science to tell us whether we will have a good vaccine or not, and how soon. We cannot be impatient. The second is herd immunity, which is frequently talked about, but very poorly understood. Firstly, it requires a herd immunity threshold. Initially, it was said to be 60 to 70%. Now, some people say it could be 40 to 50%. But even the antibody surveillance studies, which are talking about 20 to 30% prevalence in some of the larger cities, firstly, there are likely to be false positives because of cross-reactivity with other coronaviruses, like the common cold viruses and even with the dengue virus. And these false positives, when you do a mass survey, their number gets amplified, and therefore it may not be 30%, it may be 15 to 20%. But even assuming it is 15 to 20%, or even assuming it's 30%, it falls short of the herd immunity threshold. But the most important message that I want to give on herd immunity is that it is actually herd protection. Assuming that in Delhi, 60% of the people have actually been infected, become immune, their bodies will block the circulation of the virus and protect the remaining 40%. But if anybody from the remaining 40% who is not infected and immune by themselves ventures out of that protective cordon, goes to Raipur or Ranchi, where it's only 10 to 15% prevalence, that protection does not exist. Therefore, herd immunity is not immunity for the people who are not infected. It is herd protection because of that protective cordon. So for all of India to achieve that 50% or 60% threshold is going to take a long, long time. And for all of the world to achieve that is going to take a longer time. Therefore, in this world where people do travel for work outside of their protected zones, we cannot rely only on herd immunity. So what is the third fire escape route? That is where we have to take hope from evolutionary biology. When these viruses are living relatively quiescently in the wild animals because they have a limited host. If they kill that host, their own species cannot survive. So they are relatively mild in those animals. When they enter the captive bred veterinary population or enter the human population, which is extensive, large human host, travels widely, fast, the virus can actually multiply much faster and even can become virulent without running the risk of exhausting its host and thereby extinguishing its own species. But over a period of time, it has to trade infectivity with virulence. The more infective it is, the less virulent it has to become. Because if it is very virulent and very infective, it will exhaust the host. And that is why you find viruses like Ebola, SARS-1, H5N1 have much higher virulence but lower level of infectivity across the population. So this virus, as it becomes more infective and spreads across the population, is likely to shed its virulence. Even now in Europe, you are seeing in the second wave, much less of serious cases, much less of deaths. So we may also see that phenomenon in India by sometime early next year. So we have to keep hoping for that. But that's only going to happen when we create a bumpy road for the virus to travel in by physical distancing, by wearing masks, by avoiding large crowds. If you give the virus a free highway to travel in, its ability to travel and ability to retain certain degree of virulence both will remain. So we have to create a bumpy road for it to travel. So if we change our behavior, the virus can change its behavior, not otherwise. So while waiting for the vaccine, we must observe all these public health precautions. And in the meanwhile, as we resume our activities, we must also ensure that the most vulnerable are protected. The people who are elderly and the people with comorbidities are protected by shielding them from too much of movement and too much of travel and exposure. But very important to avoid super spreader events. 80% of the infections come from 20% of the individuals. Not because these individuals are genetically different, but because they're gathering in crowds. Therefore, any crowded event can actually spread the virus like a wildfire. And that is why we need to prevent large-scale gatherings, including in the festive season that's coming up. Unless we observe those precautions and observe that discipline, at least till next April, we'll not be able to rein in the virus.
I'm sure that clear message of, we need to keep ourselves safe only by adopting and practicing some of this is the most important thing. Now I come to the last question for this session, that in 1918, all over world, they have seen the Spanish flu. So many people have died. And time to time, there are several other epidemic, pandemics have come, and now we are facing this. So there may be chance, even if we come out from COVID-19, another one to attack us sooner or the later. So what are the few public health strategies you will suggest government, public sector to adopt to be better prepared for future?
Well, firstly, we must try and reduce the chances of zoonotic spread. And that we can do by avoiding deforestation and large-scale captive animal breeding, which actually provide a conveyor belt for hitherto confined viruses and vectors from the wildlife to travel easily into animal population and into human population. So we need an ecological response to the ecological origins of zoonotic infections. But in terms of the public health response, we need also to create a very strong integrated surveillance system called One Health, which links surveillance of forest animals from the forest department, from the veterinary population, from the veterinary health department, and of human health from the public health departments. These need to be integrated so that we can get very early alerts of a potential outbreak, particularly in domesticated animals close to wild animals, and then we can quickly contain the epidemic before it starts infecting the humans, and or contain it as soon as it starts getting into a small outbreak somewhere. So this integrated surveillance system is very important. Then we need very effective primary health care, whether for early detection and household symptom-based syndromic surveillance of cases for early testing, including urban primary health care. So we require excellent primary health care both in urban and rural areas, and also efficient, well-trained contact tracing by both primary healthcare teams and, if necessary, supplemented by citizen volunteers. Then we need strengthening of our secondary healthcare facilities, because we have now realized that many of our secondary care hospitals do not even have assurance of continuous flow oxygen. We need good emergency transport systems. We need good data gathering and data information systems, health information systems to be strengthened. And of course, we also require tertiary care centers with good advanced care, but we also need to produce our own equipment and become much more self-reliant, which is what the government is now aiming to. So, but public health cannot be fragmented. It has to be a very sturdy structure which is well connected and integrated across the country. And for this, we also require well-trained public health professionals across different levels of competence and different functional assignments. So to train right from contact tracing to people who are actually public health epidemiologists and infectious disease modelers, we require different kinds of competencies. And for all of this to happen, you require to invest in public health institutions, and that is what we in the Public Health Foundation of India wish to do and are doing. Because if you neglect public health, then you will always end up battling a crisis on your hands in clinical medicine. So while strengthening clinical medicine, you still need to focus substantially on primary healthcare and on public health.
So thank you, Professor Reddy, and your very clear and loud message that so far, not only India, globally, several countries have ignored the public health care in a big way. And now most of us are learning the lesson, and not only the clinical care, but along with that, primary care, primary healthcare services needs to be strengthened in this country, and that only can save us in future during our lifetime if anything like this comes up once again to manage better. So with this, on behalf of CII and my personal behalf, I want to thank you and thank you very much for your time and your excellent articulation and clearing many doubts what many of us had in our mind. Once again, thank you very much for joining today.
Thank you.